So we're going to change gears for a moment and talk about female sexual function. My name is Dr. Ramzy Burns. I am a urogynecology and reconstructive pelvic surgery fellow at Indiana University. And I want to thank the SMSNA as well as Dr. Helen Burney for allowing me the opportunity to speak today on the topic, When Being Wet Isn't Sexy, Female Incontinence and Its Impact on Sexual Function. I do not have any relevant disclosures. Female urinary incontinence is widely prevalent. There was a recent US study that showed that 62% of women report having any type of urinary incontinence, and this is distributed among stress, urgency, and mixed incontinence. Among women with urinary incontinence, 20 to 30% describe coital incontinence, which means leakage of urination with sexual activity. And up to 25% of women with urinary incontinence, they report that it negatively impacts their sex life. When we think about how urinary incontinence and sexual function relate, one of the things we can think about is the pelvic floor. We know that women with urinary incontinence tend to have weaker pelvic floor muscles, and that women with stronger pelvic floor muscles tend to have better orgasm and arousal. And we know that the duration of pelvic floor muscle contraction, as well as endurance, are correlated, again, with better arousal and orgasm. We also know that urinary incontinence impacts sexual health in women because it causes women to avoid sexual activity. Women are worried about leaking when they have sex. They also have impaired body image because they have to wear pads. Pads aren't sexy. They might leak and smell like urine or feel like they smell like urine at all times. And again, that just doesn't make them feel sexy. They also have a reduced satisfaction with intercourse. Women often feel the need to hurry sex to avoid leaking during sex. There's reduced spontaneity because they have to kind of plan to go to the bathroom before they have sexual activity. They have a decreased ability to relax when they're having sex due to fear of leakage again, which then impairs orgasm. All of these things lead to a lower frequency of sexual intercourse among women with urinary incontinence and an overall decreased desire for sex. And we also know that anxiety and depression are higher among women who have urinary incontinence, and this again impairs self-esteem. Urinary incontinence also impacts relationship and intimacy. We know that women who have urinary incontinence have a harder time talking about sex with their partners. We also see that men who have partners that leak have lower overall satisfaction and overall lower sexual function, and that couples who report urinary incontinence in the female partner have poor overall sexual experience. We know that the degree of urinary incontinence is not related to worsened relationship satisfaction, and that means that really any degree of urinary leakage can impair relationships. And so while I could spend 4 hours today going through all the treatment options for incontinence, I will not be doing so. And instead, I just want to talk about how all of these treatment options can improve female sexual function. Pelvic floor muscle therapy improves sexual function as well as urinary incontinence, and we have studies that show that it reduces sexual quality of life problems and improves female sexual function index scores after treatment with just 3 to 6 months of pelvic floor physical therapy. We also have literature that shows that treating overactive bladder with medical therapy via beta-3 agonists or anticholinergics leads to increases in the female sexual function index score in 70 to 84% of individuals after just 12 weeks of treatment. Onabotulinum toxin also improves all domains on the FSFI score, and sacral neuromodulation improves sexual function too. We have studies that show that women who were not having sex prior to sacral neuromodulation actually start having sex afterwards, again suggesting that treating urinary incontinence overall improves female sexual health. In studies looking at the treatment of stress incontinence in women, we see that there are rises in the PIS-Q score among women treated with any type of sling as well as Birch procedures, and that these are sustained over a 2-year period. We also have studies that show that women who are cured by slings have improvements in all domains of sexual function, and that patients cured of stress incontinence are more sexually active and have less coital incontinence postoperatively. And I believe Dr. Irwin Goldstein is in the next room, but I would be in big trouble if I didn't mention the female prostate. This has also mainly been a prostate session at this point. And so there's this notion that there's glandular tissue in the anterior vaginal wall with similar immunohistochemical staining as the prostate in men, and that this tissue is basically right where we put our slings. So we make incisions there, and that's where our sling lays. And the idea is that this area has autonomic and sensory innervation that may contribute to secretions involved in ejaculation and orgasm in women. And so while it's not something that we often counsel women on, and it's not something that we screen for postoperatively, there is a very real notion that dyspareunia and changes in orgasm may occur in women in up to 9 to 17%. In conclusion, female urinary incontinence and coital incontinence are very common. Both have significant implications on female sexual health and relationship dynamics. Treatment options are available, there are good overall cure rates, and they improve sexual functions, but they may have adverse impacts, and women do need to be counseled appropriately. Here are my references, and I want to again thank the SMSNA for allowing me to speak today.